I'm absolutely delighted to welcome you all to this event today. My name's Merron Simpson and I'm Chief Executive of the Health Creation Alliance. And it's great to see so many people here. Neil has dealt with some of the housekeeping. The session is being recorded, so please keep your video off if you don't want to be visible, but we do hope you will, of course, keep your camera on. It's lovely to see faces at these events. And the recording will be available on the Health Creation Alliance YouTube page later in July, and also from our website. Please introduce yourself in the chat box and do use the chat box throughout the session to share views, observation and links to resources, and that will be helpful when we come to the breakout sessions as well. And at the end of the event, we will have an evaluation, as always. Please do complete it. It will pop up as you leave, and it will help us to improve what we do, but also help to secure funding from a variety of sources to continue this work. We know there are quite a lot of members at this event, but also some of you may not be members. You may have heard it about this through other routes. You may not be on our database. We'd very much like to sign you up for membership for free. And we'll do that following the session. But if you don't want to become a member, then please could you make that clear in the chat, and we will not add your email and details to the database. So please make that clear in the chat if you don't want to be signed up. But membership of the Alliance is free. So we hope that you will want to be part of that and come on this journey with us together. So this is a joint event from the Health Creation Alliance and Rethink Mental Illness. The Health Creation Alliance is the leading national cross-sector movement addressing health inequalities through health creation. And we're a mix of professionals from many sectors, community leaders and people with lived experience of poverty, trauma and discrimination, many of whom are becoming leaders too. And Rethink Mental Illness is the charity for people severely affected by serious mental illness in England. And this event is a series of events. It's one of a series of events that the Health Creation Alliance held on the theme of health creation coming of age. All the other events from the series actually took place in October last year, and you'll be able to find them on the website, and some of you may have attended some of those. And we covered themes such as how health creation might be adopted into population health management and Core 20+5, and work on the work the NHS does to create spaces for community wellbeing and other things, NHS institutions. So this is really saying that, that health creation has can be adopted broadly and needs to be adopted very broadly across everything that we do. But this event today is special. It's a bit of an outlier, if you like. We postponed it from October because we didn't have the right partner on board. And we felt that mental health is such an important issue that we didn't want to get it wrong. And so we're absolutely delighted to be working with Rethink, who have supported this financially, but they've offered so much more than the money. They've helped us with the content. And we're delighted that Claire Murdoch has been able to attend this as well, the National Director for Mental Health, who will be speaking later and is here today, listening with her video off until she speaks. So with an amazing set of speakers who I will introduce before they're due to speak, we're confident that this will generate some new insights and help to unfold new ways of thinking about how to address mental health, which is becoming an acute issue, isn't it, in the UK? So why is health creation coming of age? Very quickly, for the last 7.5 years, the Health Creation Alliance has led a national movement for health creation to address health inequalities. In the first 4.5 years, things moved quite slowly, but then COVID came and everything changed quite quickly. COVID, of course, is just one of many destructive forces in our world today, and it exposed stark inequalities, but it also made visible some of the more hidden aspects of how communities work, became resilient, and how they thrive. And it concentrated minds on how inequality leads to poor mental and physical health outcomes, but also how health inequalities can be addressed through creating the conditions for communities to become strong through connections. So for the last 2.5 years, it's been very different. The NHS is in a negative cycle, impacted by circumstances way beyond its control. And health creation is nevertheless experiencing what might be described as a coming of age. It is undergoing a metamorphosis as people are starting to see the power and central role in system transformation. Health creation must become business as usual across all our systems, alongside efforts to treat illness and prevent ill health, including mental ill health, the subject of today's event. So our call to action then is for all integrated systems, healthcare systems, to recognise health creation as equally important in addressing health inequalities as the treatment and prevention of ill health. We want it to become adopted and embedded across the whole system as business as usual. And we will be issuing some calls to action in September that have emerged from the Coming of Age series. And then finally, before I hand over, there is a 1.5 hour video on our website on the Coming of Age page, which provides an introduction to health creation. So we won't be covering that here, except I will quickly run through the main points. So Neil's going to put a slide up for me, and this is the summary version. So health creation is the process through which individuals and communities gain a sense of purpose, hope, mastery, and control over their lives and environments. And when that happens, their health and well-being are enhanced. And that's the definition we use. There are others as well. People need connection to gain confidence, to gain control. Building meaningful and constructive connections between people increases their confidence, leading over time to greater control over our lives and the determinants of our health. People also need an adequate income, a suitable home, an engaging occupation, and a meaningful future. But having control helps them to gain that. And these are the 3 C's of health creation. And they're a new way of conceptualizing and drawing together a range of theories that have long existed, including from Michael Marmot, Amartya Sen, Harry Burns, Viktor Frankl, Aaron Antonovsky, and many others. And it's often referred to as salutogenesis. So the 6 features of health creating practices, communities consistently tell us that there are some things that make a big difference to their health outcomes. And it is backed by evidence. And they are, by diligently embedding these 6 features of health creating practices into all our relationships, we can drive change across the system. And they are listening and responding, truth telling, a focus on strengths, what communities can do, self-organizing or connecting for a purpose, reciprocity, the give-get in the relationship, and power, of course, the power dynamic in relationships, really important. So power shifting and power sharing. And those are the 6 features. If you build those into the things you do, you will be helping to create the conditions for people to become well and to stay well. And we've recently added these 4 relationships because we've developed a relationships first approach, which says, let's see what we can do by changing the way we relate to each other. And integrated systems need to focus on all 4 of these. So there are 4 communities, 4 relationships. One is between community members. This supports the building of collective agency and community strengthening, which is health creating. The relationship between the NHS and communities. And this enables a different conversation and the possibility for communities to play significant roles in partnership with the NHS. Between other local partners and communities. So this can provide routes into listening to communities that might be mistrustful of the NHS, for example, by trusted VCSE organisations, and between the NHS and other local partners. And this offers the possibility of better access to services that influence the wider determinants of health, such as housing. So hopefully you've clocked that this is a framework that's very powerful. We're using it in several systems to guide transformation, and we use it as a plumb line against which to measure activity in innovation and services, measure progress towards health creation against that. One of our members once said, if things are going right, you'll find the 6 features of health creating practices there. They'll be manifest within it, and that's true. So I'm going to finish there. Without further ado, I'm going to invite Lisa Holden, who's one of our active lived experience members, to just bring that to life really in her own words. So over to you, Lisa.
Yeah, hi, thanks, Merron. I'm reading from a script so that I don't go off track. So if it looks like I'm not looking at 10 people. So you may have seen the recording from last year's Coming of Age first session, the introduction to health creation. And it's about me speaking publicly about my personal story and how I came across health creating methods and the framework, and most importantly, the 3Cs. So today I'd like to tell you why I think we need to use the health creation framework in the communities we all live in to support better mental health and well-being. People like me, who could be described to have multiple lived experiences of poverty, trauma, discrimination, and also a mental health condition, are finding the 3Cs in the health creation framework to be life-changing. The 3Cs, when used consistently, can be a great self-help tool. Consciously repeating the words confidence, contact, control in times of difficulties help me to focus my mind and find the actual confidence to get out of my house so I can maintain actual contact with people in my community and retain actual control of my life. Continuing to engage in the things that I need to do, even if I'm feeling mentally unwell, has been made possible to a large extent in the recent years by the application of the 3Cs and the wider health creation framework. So there are 4 points I want to share with you today. The health creation framework is a life-enhancing and life-saving approach that needs to be adopted by service providers. Supporting people to have the confidence to get connected to their own community is very important for all citizens. To feel in control of your own physical and mental health is a vital part of feeling that you are fully functioning as a human being in full control of one's faculties. This is particularly important to people who have survived mental illness. Feeling we are capable, valid, and equal members of society with personal control over our ability to live as independently as possible is a basic human right. Not having to totally depend on others to help us survive is very important in retaining control of our lives. Good mental health care means we can live our lives as individuals within our wider communities. Community-based groups and activities can provide us with a social infrastructure where opportunities to connect to other people, but also to our individual interests, ambitions, and passions. These kind of activities are available in communities already, to name but a few: gardening groups, outdoor pursuits, creative arts, dance groups. They can all help to make our lives feel much more worthwhile. Inclusive access to these activity-based groups provides a place where people can support other people to learn about the 3Cs of health creation and also the wider health creation framework. My second point is that interventions are often getting to us way too late in our downward mental health trajectories. Often after long periods of waiting, we can end up becoming more ill and in more need of more fixing, which is much more costly. Fixing people when their issues are small is a much more sensible and cost-effective approach than waiting until people are in full-blown crisis. So this probably requires some sort of connecting to citizen-led community activities at a much earlier stage. It can enable people to hold on to their mental health, and it can be seen as a form of prevention, which is also known as early intervention. As and when deeper treatment options are required, professionals can take services to these community spaces and build on the citizen-led offer. So developing health creating approaches and community-led networks just has to be the way forwards, in my opinion. My third point is that we need to address how we can ensure funding gets to the right people and the right places. If funding is allocated carefully and in focused ways, community activity can offer a low-cost, maintenance-style service as well as an early and crisis intervention option. This helps to prevent people's mental health from being partitioned off into inpatient services and hidden, which invariably also costs the system a great deal more to fix. Ongoing attendance at community-based groups can support a fuller recovery and support a better long-term maintenance of whole communities' mental health. Reducing or preventing relapse can also be seen as a positive outcome, with a real financial cost benefit when this community approach is used. It seems almost impossible these days for most grassroots community-led groups to access enough long-term funding to keep their doors firmly open. Community-based activities are often being left to wither and risk closure due to the lack of proper injections of health-derived funding. Money seems to be found for shiny new projects that seem to hit government targets, but many of these are not sustainable in the long term and often just don't dive deeply enough into the causes of mental ill health to reach the people where they are actually at in their communities, in their local communities. My final point is to highlight how I believe health creation and a health creating infrastructure could be critical in the field of suicide and self-harm prevention. People are being encouraged to talk openly about suicidal feelings, which is often a criteria to access clinical services. But when they do open up and speak, there's often a long wait for follow-up appointments with nowhere to go for the person in need of the help in the here and now, which puts additional pressure on community services. We're in danger of reaching a critical position where there are just not enough clinical appointments for everyone to get the deeper levels of help that they need when they're at this level of distress. This can leave these people at even more risk of suicide completion. Exploring how we can use health creation frameworks in this arena needs to be undertaken, in my opinion, so we can understand much more fully how a health creating infrastructure could be of great benefit and great use to the people in the communities who are often left dealing with the situation when the mental health care system can't cope. So, in my opinion, if we miss the opportunity of developing a citizen-led community offer at this point in time, with clinical models interfacing and interconnecting, then we risk having much less healthy communities, and this in turn will affect us all. We will be left in the community dealing with the situations. Supporting citizens to work much more closely with service providers to find ways of working together to develop these health creating infrastructures will surely result in much better collective community mental health outcomes for everyone, including service providers. Thanks for listening to me, and I hope at least some of what I've spoken about is of help to highlight how health creation and the 3C's way of doing things is a cost-effective way and should be fully supported and embraced. There. I don't know how long that was, but hopefully it was in time. There.
Thank you, Lisa, for what I think was a very powerful explanation there. And I think this idea of health creation infrastructure is a good set of words that we should start to use much, much more. So we're going to move on now. We're not too far behind, and we will catch up, so don't worry about that. But I'm absolutely delighted to introduce our next speaker, who I met recently, and her name is Suad Duale. She's a psychotherapist, researcher, community activist, but much, much more than that. And she's very embedded in her own community of people of Somali origin and heritage in Birmingham. And she's going to be talking from that perspective. So looking forward to hearing from you, Suad. Thank you very much.
Oh, thank you. Thank you. And hi, everybody. And I'm sorry. I don't know, always you get nervous when you're doing something like this. My name is Suad. They call me Suad, and they call me call center. And actually, there is documentary. We did research in COVID time. And the reason I got call center call was because I work with the community. And it's actually a good opportunity today. And I know the limited time we have. I like to start with question. And before I go to my presentation my first question is, did you think your hair, your color of skin, your language, how you look, it makes it different when you see health professional, especially when it comes to mental health? And you can type the answer if you say yes or no. And the same time, so I want you to hold that. And the other thing I want you to consider is this big word, health professional, especially in big organization, they use the expert. This person is expert. And I wondering what does that mean? Who is the expert? Or how they get this title and who created? And the other thing I want you to think about when I'm doing my presentation is, did quality have color? Or quality is always something all of us, we deserve it. And I hope I can see my slides. If you give me my slides, just to guide me. Okay. I'm sorry I cannot see all of you. It's just to guide me. Obviously, when it comes to mental health, for somebody who work in mental health and part of it, And I'm talking about I'm somebody who grew up in refugee camp. I see everything in my lifetime. And at the same time, I was an interpreter for NHS for 7 years. I've been behind doors and I see everything. And I think today I will entitle my opinions. And I want you really listen to me, because it will make a difference. Because we talk a lot, we have meeting, I don't want this meeting today just tick box. Next slide. And we know when it comes to mental health, the diagnosis, Black and the BME ethnic minority background, they diagnose that they are underserved, misdiagnosis, got lower surface. But imagine all of this, and when we're talking about quality, and I think sometimes this is a big word. I'm still speaking broken English, and that's why I tell my student, what does that mean? I really don't mean anything other than paper and paper and paper. Next slide, please. And this is where I want you really to look around, and I want you to look with me. When it comes to mental health in UK, all of us in NHS mental health, especially, it's the crisis. We are in crisis, especially in COVID time. We realize how this crisis impacts. But in COVID time, I remember I was doing psychoeducation for 1,500 people in one time. And the reason was, it's no surface, they wasn't able to access it or understand them. The next slide. For Mike, the question it will be, next slide, please. When it comes to Somali, and especially I will talk today, I will focus on Somali community, because that is where now I'm talking about it. For me, I see different community and I work with different community. The health quality, what is impact on the mental health? And people are homeless. Now we doing big project of research, the homeless impact, physical and mental health and homeless in Birmingham for single mom. And it's horrendous, the thing is happening. The stereotype, the language barrier, these people come for war and trauma, the size of family. There is actually, when the mothers say, oh, I have 5 and 6 or 7 kids, they actually look down. It's something, why, how dare you that? And the mental illness, because they're not able to trust the surface. They cannot trust you. And the reason that yesterday I got a call from mother who's saying to me, my daughter, she didn't leave the house for 2 years and I don't know what to do. And the psychiatrists have given a diagnosis. The mother, she don't understand the diagnosis and she don't know how to help her child. And this is all happened for the last 2 years. When we talking about cultural identity, we're not understanding. It's nothing making, are we helping people or are we harming people? And at the same time, the economic background. This is all, and disability, a lot little disability. When you use an interpreter, a lot of people cannot pick it up and they cannot understand, because we know when we're talking about everybody, if I said to you, think about something, the image we have in something victim or something abuse, there are a stereotype. And I think that is next slide. And this is the other thing we're not aware of it and how this impact on this community. And the big thing for somebody who, now I'm nearly going to finish my doctorate. I've been through all of the training and I've been all this. Racism and systemic racism is real. And I think we can push it around. We say, oh, we're trying to be quality, but we're lying to ourselves. And the reason I'm sorry, because no one wants to, when we come to individual, all of us will want to give the best. And I think all the professionals who work in the place, I'm hoping, all of them, they wanted to help the patient, the client, the best they can. But the reason is the bias we have is so ingrained for a long time, the change is not happening. Is you cannot see the person because so many things is going around you in one time. And that is if you go to the hospital, just racism, the experience is so really affect people's mental health. And then systemic racism, same time, how the system works. And the same time, are we treating everybody equally? Okay, no, because everybody have different need, individual and people who come in for collect culture, they need systemic, they need a community. I experienced horrific things in COVID time because I see people mental health deteriorated so badly. But what we did? Everybody was talking about, oh, we join online. What about the people who can able to? Most of the majority Somali community are single mom. They're not able to access online. Children in the West not able to access online. I had young people coming to me and say, I don't know what to do. It's nothing. And the mental health is hidden so badly because the behavior in school is, oh, this child is his background, is behaving. No one able to pick up this child need or have this child, whether you have autistic or disability learning, no one able, because the waiting list is ridiculous. That is all of us we know. At the same time, what we do, because the training, whether it's university, whether, when we talk about racism and we wanted to cover it, we do little workshop. Oh, you need to be aware, accepting everybody. Our training, how we've been trained, whether it's university or organization, they not prepare anybody to be able to see the other person without who they are. They're not able. You cannot do something you never been know about it. And that is my problem. People think racism is not there, so systemic racism is not there. You cannot tell me for something you're not able to see, because if I tell you, and I'm get angry with this, people think, oh, the community, they are struggling. This mother saying to you, I don't know, I need to help my child. How can I do? This is where the problem is, because we cannot able to see them. We cannot able to recognize what it is. And that is where is the difference. It is the training, whether it's like psychological assessment, whether psychiatrist assessment. There, I've been invited so many assessments, they was not able to pick up. In Somali language, it's no word for depression, no word for anxiety, no word in trauma, and no word in all of the diagnosis of mental health. Can you tell me how you're able to communicate with somebody? He don't have the language capacity for the diagnosis you're giving, or mental health, what does that mean? But that means it's completely different. And I think the reason Somali community suffering most in systemic racism is actually, there's 2 studies now, we're hoping publishing it soon, because they are one of the suffering community, especially in West Midland, where they come to houses, where they come in mental health and surface, everything. The report a couple of years ago, we did recommendation for mental health. It just was report. I feel like it's just wasting time. That is one of the things, and that is the system. And because there is economy and colonization system going on, and desperate people, how they receive in community. And I think people see, okay, who you surfing, who you seeing, and that is systemic racism is real. It's real when it comes to mental health, anywhere in anything, and it got worse. It is not getting better. And that is why I want you to be aware. Next slide. I hope I'm good with time. And the gap is like community discussion, because everybody, you are there. I just meet you when I need to help you and take your books. Not fully, so the care system never be understood in community. Like I get the call, it would never pass for me, no week. I never got called for community. Somebody asked me, did I'm safe to talk to the social worker? Did I'm safe to talk to the mental health? Did it safe I go to therapy? I'm safe to psychiatrist medication you give me safe? Should not be my job. It should be all of us job. And because this is and the same time, mistrust is playing a big role, and it's still we're not able to address that. And that is this other thing. And at the same time, people not understand what mental health, and this, when we ask myself to, like, we have ego, we think I'm here to help you, that give me entitlement. Oh, you should be grateful and you should be understand me. And that is actually why, how this person, how is the language is we understand. And that is the gap, and that is the gap everybody don't want to come through it, because we need to train, whether including education system, whether people who study in psychology, and with this is all this making different to understand what is, how we can include these people in the service. Next slide. But this gap, to be able to close it and to make it different, how many leadership we can see to coming for community, especially Somali community? So far, I know is zero, especially in Birmingham. Education, heart professional, sensitivity of culture, and especially when people come, I saw in my eyes, I was sitting in assessment with psychiatrists talking for women who have extreme trauma, and I've been called because as consultant to that case, and I say, let me wait when psychiatrists finish the assessment, what diagnosis will come before I talk to them and what I see. And the psychiatrist was asked, did you get flashback? No. Did you get nightmare? No. And did you everything fine? Yes. But something like that in our culture is, what we learn is, you don't say to people it's a shame. You need to be strong. You don't tell how you feel. And the nightmare is actually dream. So if you say, did you have dreams? Yes, that would be nightmare. In assessment, you wanted the nightmare. You wanted to get the trauma symptoms, the body and BHC trauma, because you need to tick boxes. When you're trying to tick these boxes, it will not fit this community. It will not fit their language. It will not fit their identity. But what you diagnosing, actually, did you help in them? I don't think so. And at the same time, we need to create, there is no common gap between the community and the surface, because the surface, they're not coming to community, they're not talking. The only time they meet each other is when somebody harms somebody, or when somebody who is in danger. And I think that is not a healthy place. But what we will need for this is how we can help is more understand each other, and at the same time opening diagnosis. For my first question I was asking you was, who expert? We taking people to say, oh, this expert for this and this. My question is, how that person become an expert? We making people expert, we giving people title. And for me, the expert is the people who really in the community, the people who are really, they have the pain. We need to listen to them. They're not sitting in the table. I think people, it's easier as human to be biased. And when you think you inviting people in the table, in the discussion, you inviting people same mind as you. And I think this is what happened. I think this is the main point, people not having aware of it. And I think Somali community now, they're suffering more than ever, because in mental health, it's short time. I cannot tell you how it is. You can email me if you need more information. Sometimes it sad my heart and it break my heart. The reason I want to do psychology was I could not get help for a boy who been raped, and all his family was later. The mom was hospitalized, being sectioned. But this is between death and life. And the other day, I have two boys killed themselves 2 years ago. We burn out. I don't think no one understands it, and I feel like it's not just, I don't want to just tick in box to you and say, oh, here's the data. It's not about that. It's more, I really want you to, wherever you do, wherever you work, just take with me, listen what actually read mean, see the person. And I think that is what matters. See the people, and then you're able to help them. But thank you. I hope I got right time, and I'm sorry if I got over the time.
Suad, thank you. No worries that you've gone slightly over time. It's only a little bit, and such a lot in that. I'm very struck by, you know, the point you made about the Somali language doesn't have a lot of the words that we use as a diagnosis, which implies that we're kind of labeling people by the diagnosis, and the grounds for having that conversation are really not in place, because there's no understanding of that, because the language, you know, is different there. So thank you for pointing that out to us all, and I feel like I've learned a lot from your presentation. Thank you also for pointing out the gaps, and also how the gaps might be closed, because it's really helpful for everyone here, I think, to have, you know, some pointers to what they might do about it. There's nothing worse than going away, you know, feeling that, you know, you can't do anything about it. I think we can do some things about it, and thank you for that. So I'm very grateful for you starting us off here with that presentation. Okay, so we'll move on to Alisdair Cameron, who is not the Alisdair Cameron as such, but another the Alisdair Cameron, director of ReCoCo, one of the recovery colleges in Newcastle. And I'll allow him to explain what that is. And Alisdair, you, as well as having lived experience, you work with many people with lived experience, so you're well grounded in what it is that works, and what are the barriers here, what are the gaps and the problems, and what might we do to bridge that. So over to you.
Okay, thanks, Merron. I apologise if there's any noises off behind me. Yeah, right. I've got some slides. I believe Neil's got them prepared. I'm heartened by the fact that nobody stuck to time, because 10 minutes is quite a tight schedule, but I'll do my best. Okay, so let's talk about health creation, etc. Yeah, I mean, in a way, it's one of those things where you've got to start off like, what are we talking about? What are your definitions? And you know, when we're talking about mental health, we're talking about, you know, creating a movement of health creation, activism, change. What is impact, etc. And you will all have your definitions, and definitions are like toothbrushes, because we've all got one, but you don't necessarily want to use somebody else's. Okay, next slide. Thank you. Thanks, Neil. But having said that, here's a definition of what we're really talking about in the round, with the next slide, if it comes up. Okay, this is actually a WHO definition. It's from the preamble to the creation of the WHO, so it dates back to 1946. So it's actually older than the NHS, which has been having its 75th birthday jamboree this week. So what's notable in there is, yes, it makes mention of physical, makes mention indeed of mental, but expressly there it says social well-being, and it also expressly states about health not merely being the absence of disease or infirmity, which is a hugely important thing, and I'll come back to that as we progress. But if you do nothing else, I think just think of, when we talk about health creation, please consider all of the dimensions that are contained in this definition. I find it very, very helpful and very useful for framing how to work. If you can have the next slide, please. Great, thanks. Okay, and I'm really sorry, this has got an animation element, so you'll have to go next. So, you know, when we're talking definitions, let's just start with how we talk about people who are in receipt of services. Get patient instantly places people in a medical model, also has actually connotations people having to wait, which is increasingly the case. Thanks, Neil. We'll get client, you know, people quite often use that, particularly in social care, instantly places things into a transactional, almost commercial kind of relationship. Another term that's quite common, service user, very commonplace these days, but it carries its own connotations in there. It's implicit in there are two key assumptions. One is that there is a service that's going to meet your needs, and B is that you are able to make that to make use of that service. There's an awful lot of people who there isn't a service for their bespoke needs or for their particular needs. There never will be. The cavalry is not going to come. And there's an awful lot of people for whom a service spec amounts to a whole set of exclusion criteria. Next. Thanks. Consumer, this is the way that aspects some health coaches describe themselves as a consumer champion. Again, it places things in a commercial transactional situation. So even the language you use determines how people interact with health and social care systems. It frames the discussion. In some ways that can be limiting. And in a mental health context, you also get people who describe themselves as, thanks, Neil, a survivor. Interestingly, many years ago, people, if you asked them what they had survived, they would actually talk in terms of having survived the mental health system and the iniquities visited upon them by rather draconian measures. These days, people tend more to talk about having survived particular traumas, etc. So moving on, it gives us a dilemma. What do we do when people are seeking help for issues that they are facing? Do they have to play up that aspect of themselves in order to achieve the systemic change and the change in themselves that they want? It's a very limiting thing to do, to have to adopt one aspect of one's persona in order to secure help. Furthermore, and if we move on to the next slide, one of the big problems that we do encounter, particularly in interfaces with the NHS, is that the NHS is really good at many things, but it is kind of constitutional or institutionally inclined to deal with single problems in a linear fashion. And that means that actually, when you first encounter a bit of the NHS and you get given a diagnosis, it could be drug and alcohol diagnosis, it could be a mental health diagnosis, it could be learning disability, it could be chronic pain, whatever it is, that's almost your identity set in stone as far as the system's concerned. And or you get seen as a member of a marginalized or a racially minoritized group, or you get seen as somebody from some other structurally oppressed group. And that actually overshadows you as a whole person. I'd safely say that, at ReCoCo, we, to answer one of the questions in the chat, we deliver lots of different groups and courses, ostensibly around mental health, but 99% of people who come to us have got other stuff going on, lots of structural oppression, lots of poverty, lots of drug and alcohol issues, neurodiverse, pain, fibromyalgia, COPD, diabetes, you name it, all the consequences really of just having a shit life. And in amongst that, we need to start thinking about people's lives in the round, as opposed to them having to shop around to deal with, a problem here and a problem there and a problem there, because all the problems interact, those problems are intersectional. Next slide, please. We're further hampered by the fact that health gets siloed off in political terms. Mental health, for example, is laid at the feet of the NHS. Most of the major determinants of mental health problems are actually social, and a lot of the solutions to those determinants lie in the political realm. But that's a conversation that NHS leaders and so on are kind of reluctant to address. And they're sort of saying, "Oh, we don't need, there's not too much we can do about that." So in a way, the blinkers are put on, and we're not looking at some of the major causes of people's distress and lack of well-being. So next slide, please. Even if you are able to access services, and that's not a given, and even if you're able to, get over certain thresholds for your eligibility, you'd be doing very well if you managed to get 45 minutes or an hour of direct input in a week from a professional clinician. In fact, that would be quite an exceptional amount to have. That then leaves another 167 hours in the week. Now, as far as the health and social care system is concerned, that hour that they put in is the crucial hour. That's the golden hour. That's where all the money goes, and that's the most important part of it. If you're on the receiving end, and it's important, you're in receipt. It's not a reciprocal thing. If you're on the receiving end, it's another 167 hours in the week. And to be honest, if things aren't going right in those 167 hours, then that 1 hour of clinical time isn't going to make a damn bit of difference, really. So it's almost as if the system is looking at people through the wrong end of a telescope. Next slide, please, Neil. So what is the solution? Well, there are no easy solutions, but the health creation approach has a lot of tips to at least improve things. I'm not saying that it is a solution. So it's about connection, and encouraging people to pull each other through, not seeing people in terms of their diagnosis or deficits, working with and augmenting what we do have, people in the round with their hopes and their dreams, their skills and their talents. Knowledge resides in people, and that includes staff, and allowing staff to use their own knowledge of their own experiences. So it's allowing staff to be people, and what we might term patients or service users as people. So it's people to people, as opposed to people role playing. I'm adopting the persona of a service user. I'm adopting the persona of a straitjacketed clinician. So it's about broadening things out, broadening out the notion of what health is. In a way, some of the terminology we have, such as mental health, gets in the way, because mental health can be seen as quite a narrow thing, and it's just laid at the feet of mental health services, when actually looked at more properly, it covers all sorts of dimensions of life. So adopting a health creation approach can assist in some of the shifts that we need to see. The greatest asset we have is people, and it's in people that all the knowledge resides. There aren't really going to be tech solutions. AI isn't knowledge. It's algorithmic data, pattern recognition. But the asset we have is the people. But we don't make enough of an asset of both the knowledge that resides within communities and individuals, through their experiences, and pooling that knowledge with everyone who's done the evidence of research and so on. I'm optimistic we can actually free things up. We do run a big risk in time, when times are tough, of reverting to type, and ICBs do feel rather like they're keen to revert to NHS project management approaches, Westminster and NHSE top-down approach controlling. We need to push back against that. We need to reassert ourselves, to liberate people, liberate those who are lower down, and that includes people in their communities, and trust people. They're inherently good. They will want to do the right things, whether whatever role they're fulfilling. Being transparent, getting away from micromanagement, but also accepting difference and diversity. And that's both difference and diversity along the kind of protected characteristics route, but difference and diversity in outlook and approach as well. Don't look for magic solutions. The amount of times I've seen policy documents of late saying technology will do this, that, and the other. You might as well just say magic will do this, that, and the other. It's not. The health and social care system has millions of people employed within it. There are millions more people living in communities who've experience of how best to tackle various problems. What's worked for them, what's not worked for them, who are able to create safe spaces where others can discuss and share their experiences. But we need to let that happen, and to relinquish control and get away from some of the status wars that go on. And I think that's probably about 10 minutes worth.
Thank you, Alisdair. Wow, you were so into that, and you know, saying such important things. I can't reflect all of that in the 30 or 20 seconds I have, but you ended there on power shifting, essentially, on just, you know, being human to human, people connecting with people, not always trying to build the next app to get that engagement, but, you know, actually changing ourselves as, and for, you know, services to see that they're equals, and that whatever service users, communities, whatever you want to call it, are part of the system and can be part of the solution. That is, you know, the strengths that are there. You mentioned the deficits that people often see in the labels, but actually a strength-based approach is the way forward. I'm going to finish there because we need to move into the panel session, and you will have more opportunities, Alisdair and Suad, to interject in that. But I'm going to hand over now to my colleague, William Higham at Rethink Mental Illness, who is the Director of Community Mental Health Unit at Rethink, so who's going to facilitate the panel session. So starting with a couple of speakers. So William, you take the reins.
Thank you very much, Merron. I'm going to keep on moving briskly so we hear from the next two speakers and have a small conversation, and then we keep Claire where she should be, and we have time in the breakout sessions to kind of hear about your reflections. Amazing session. So can I turn first to James Duncan, Chief Exec of Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust. And James, in 5 minutes, to kind of a little bit about how you're addressing health creation.
Thanks, Will. 5 minutes. So what am I going to say in 5 minutes? Right. First of all, I think, Lisa, you pretty much said everything I would want to say, to be honest, at the outset of this conversation. So it makes what I have to say maybe a little bit easier. Suad, I have to say what you said was powerful, challenging, but it's not surprising, is it? And you talked about how difficult it is for the Somali community to navigate the system. Well, frankly, we've created a really complex system, haven't we? We've created a really complex system that frankly is hard for anyone to navigate, and so much more difficult in some circumstances than others. But frankly, it's a bit of a labyrinth for anyone. And we've become a bit of a crisis service, haven't we? We talk about the National Health Service, but really we're dealing with crisis. And the more we deal with crisis, the more we put the resources in to deal with the crisis, the more it becomes a vicious circle and I guess just a downward spiral. But it really doesn't have to be like that. It really doesn't. And I think the answer is in community. The answer is in connection. And Alisdair talked about connection and relationships. We've become really, really institutionalized. You know, we've created specialist team after specialist team, and it's so hard to navigate through the system, when actually we need to make that simple, we need to make that easy. And we, as an organization like we are, need to reach out into our communities. And we've been talking about this, and it's there, it's set out within our plans and aims as an organization. But it was said most eloquently to me in a big meeting we had, where a GP was talking about forming the gang. And that's what it's about. It's about forming the connections. It's about forming the gang across communities. We have huge assets across our communities, and we just don't connect. We don't work well together. So we absolutely can simplify the way we do things. We absolutely can reach out. Why do we accept things like waiting lists? Why do we accept the gaps and holes that we've got in the system? Why don't we think about actually how do we collectively work together to problem solve? And that's easy to say, but it's actually really, really hard to do, because simplifying complex systems is really hard. And there's a real danger. We all get paralysed as well, because you get paralysed by the size of it, you get paralysed by the difficulty, and we can talk a good game, but we end up doing nothing. And I think there's something around having a real focus on collective problem solving. And actually, whatever you do that shifts the dial, it shifts the dial, so it's worth doing. So let's not try and solve everything at once. Let's just say, what is it that we can do? What can we solve? So if there is an issue with the Somali community, if they find it hard to connect with us, what can we do? What can we do to reach out? What can we do to build a sense of belonging and a sense of community? We've got in our patch, we've got the biggest Haredi Jewish community in Europe, and that's a culture which has real issues in recognizing and working with mental health services. And how do we break down the barriers? How do we reach out? How do we work with the people in that community to build up trust? Because without trust, without relationships, you haven't really got anything. There are loads of barriers in the way. So we're all institutionalized. We all like to blame the other side. So we all say it's that person's problem or it's that person's problem. And actually, if that's your point, if that's where you come from, it's really hard to build a constructive relationship. So actually, we've got to forget a bit about that. We've got to build those human connections that actually help us to work through problems in a real and realistic way. There's all the stuff about fear of risk. There's all the stuff on our side around professional boundaries and what we hold dear. But frankly, I think we're all after the same thing. Fundamentally, we are all after the same thing. So let's just start talking the same language and maybe we can make some progress. I'll end it there.
Not only was that an inspiring call, but it was also, I think, exactly 5 minutes, James. So thank you very much on both of those things. I'm going to hand over now to Dr. Amanda Skeet from St Basil's and Birmingham Women's and Children's NHS Trust. And ask you again, Amanda, for 5 minutes, and then the other speakers will join back in and we'll have a very short conversation before we hear from Claire.
Thanks very much, Bill. I also have a piece of paper because, as Merron knows, I do go off track and will be longer than 5 minutes. So nice to meet everybody, and I'm sort of already really fired up just by the chat and what I've heard. So a little bit, I'm a clinical psychologist, as Will said, and I've had the privilege over the last 12 years of being seconded from Birmingham Women and Children's NHS Trust, where my full-time job, if you like, sits, to St Basil's, which is a registered housing association company and charity who specialise in supporting young people who are homeless or at risk of homelessness. And they are a regional service across the West Midlands, and provide sort of a range of services from helping young people who might find themselves in housing difficulty or in precarious housing, to outreach services, to providing projects, hostels for young people who don't find anywhere to live. So just to give you some idea, a third of the young people we support are care leavers, and about 40–45% are care experienced. Where we see really overrepresented populations of young people with neurodivergence, so that's autism, ADHD, again, people who, what we know, have often been let down by sort of social care and health systems. St Basil's, I'm been passionate to work with them because they really understand the complex interplay between housing and homelessness and mental health and physical health. So we tend to think about it like a table, and we see a table with 4 legs, and we all have needs, but generally we're in a position where those needs can be met. So income, having a stable income, employment to generate that income is one of those legs. Health, both mental and physical, is another one of those table legs. And community, friends, family, that connection, that feeling of belongingness and acceptance that we all need as human beings, that's the third table. And safe, affordable, secure accommodation is that other table leg. Now, actually, if one of those goes, so say my mental health starts to suffer, I start to experience mental health difficulties, but I've got those other 3 table legs, then my table doesn't fall over. I'm going to get support from my community, from my friends, from my family. I've got a roof over my head, so that isn't an additional burden. But if I'm sort of got 2 or more, so I haven't got safe housing and I've got mental health problems, that's when the table falls over, my needs become difficult to meet. So we know that there's this interplay between housing and mental health. And I've got sort of some facts, but actually I'm going to tell you a story of a young man who I jumped on a meeting today. And his early experience as a child was very unstable housing. So mum was often in abusive situations, she was moved, so school wasn't a constant, because if you move areas then you have to move school. GPs isn't a constant, because again you move areas, you move GPs. And so he had this very unstable sort of early life, and then sort of trauma within that. We don't know an awful lot around sort of when he's 17, 18 years, but relationships between himself and his family became more and more fractured. And slowly, because he wasn't in college, he wasn't attending any health appointments, he becomes more and more excluded and marginalized. So you can see how sort of unstable housing can impact on those relationships, on your community. So we go through, he ends up rough sleeping, his mental health deteriorates, he copes by using drugs. And the meeting I was at today was actually sort of trying to kick in a few doors, because, you know, and Suad talking about discrimination, he's seen as a young person on drugs and he's homeless, and that's the lens he's seen out. So the fact that he has a full diagnosis of psychosis, that he has he's extremely acutely unwell at the moment, is completely and utterly masked by the fact that he's homeless, or, well, we've got him in accommodation, but that's about to fall down because the housing provider is saying we can't meet your needs are too high, your risks are too high. But from the mental health side, it's seen that, well, he needs to go into a drug program. We're arguing, and I think we did argue successfully, but with a lot of support, that actually his need, he didn't have the capacity or the insight to actually seek that help. And we need our mental health colleagues to actually come in and support us and work in partnership. So hopefully that gives you a little bit of that understanding of that sort of really complex interplay. So what helps? What are the solutions, as we've heard from James and Suad and Alisdair? Well, the first thing is that's really important to St Basil's and our partners is we have a very approach called psychologically informed environments that's really aligned to health creation. So it starts with the relationship and doing with people, not doing to them or for them. It's helping our staff feel confident and competent to work with people and ask questions around their mental health. You know, so what's that like for you? When you experience voices, how does that feel? What support can I give you when you're struggling? Co-creation is absolutely fundamental, and co-participation, you can see here, these are our youth standards, which were designed by young people about the services that they want, not by me, because, you know, a menopausal woman in her 50s, I don't actually know what's important to young people. And I wouldn't have put digital access, because I try and avoid IT as much as possible. So again, it's listening to the people with that experience. They're the experts who can help guide services and development. We have that emphasis on holistic support. So St Basil's and we work with lots and lots of other housing providers, is really about understanding that actually, yes, having housing is really important, but you also need employment, meaningful engagement, you need connection with your community. And again, fitting in beautifully with the health creation, we use the CHIME methodology from Mary Leamy. So connection, hope, identity, meaning, and empowerment. These are all the determinants of mental health recovery. We've got the evidence base, we've got the research, and we really need to pull it all together. I think hopefully that's my 5 minutes.
It absolutely is, again, on time. Thank you both very much. And just as Suad and Alisdair rejoin us, just a quick reflection from me. So Rethink Mental Illness, we've been working about 7 areas, trying to build alliances with the local voluntary sector to work with NHS colleagues to kind of, and social care, to try and build those community assets James spoke about together, and make them wrap around the individual with all of their support needs, which are, you know, to the point that Alisdair made so strongly, there's no magic hour once a week that can solve everyone's problems. It has to be a completely holistic approach. And I think that's partly why it's so exciting to be in this webinar this afternoon. We're having the conversation we know we need to have, but no one really has time to have because the current crisis is so overwhelming. Just a couple of very quick thoughts, and then be keen to bring back in the panel. I mean, picking up on some of what's been said, I really liked James's thing about picking something we know we can solve, you know, and doing something about it now. I think that's really important in rallying the community and the voluntary sector. Sorry, excuse me, there's a dog in the background deciding to do that shaking thing dogs do, in case you wonder what. And I think that thing of finding a clarion call led by co-production that can just get people acting now is really, really important on the health creation side, not least because with everything else going on, it's very hard, with all respect to NHS colleagues, to do too much or solve too much at once. And I think just returning to this point about moving power around, I think sort of everywhere we've seen health creation type work happen in the community, it's looked different, but it's always had in common that it's moved power around, it's moved resource out to the community. And we heard right at the beginning from Lisa, you know, a lot of charities are struggling right now without resource. And it's all been led by co-production. So I really embrace that. I think we should all find one thing we can do together. And I'll look now at the panel to see.
Just to add, well, unfortunately, I can only spotlight 4 people. So if you'd like to ask your question, and then I'm going to very seriously kick you off and add Alisdair, if that's okay.
Brilliant, that's fine. Let's bring in James. And
yeah.
well,
okay.
It's nice to see you briefly, everyone.
Yeah. So this thing about power and resources is it's really important. It's one we just get stuck on, isn't it? And we get stuck on, and we have the right conversations, but then it all gets stuck because you need a business case, and actually you've got to bring your resources to the table. That's the thing. We've got to bring our resources to the table, and we've got to work with what we've got. Over time, we can make some of those shifts, but actually, just starting with the relationship, starting with that connection, using our resources that we've got in a different way, we can do some of that really quickly. So I think for me, there's a lot around mobilizing ourselves and not being paralyzed by the system we work in, because it really does take ages to go through all of those issues, and it puts the barriers up, and we've just got to do everything we can to enable that bit of co-creation and that bit of can-do.
Here, and say that as someone working in charity that just had to go through 13 boards to get a co-produced solution. Who else would like to come in? Alisdair.
Just to echo what James said, I think doing some good is better than doing nothing. It's doing better than nothing. You've got to start. You've got to get some momentum going. I think what doesn't help is that the levers of power keep changing, which is not very helpful, and it's against a wider situation of political, almost existential instability, so that people are not quite sure how to get things done. But I think if we, lots of small initiatives are still going to have a beneficial effect, and I think I'd far rather, I'm a natural born pessimist, but I don't want to come up with a counsel of despair. And I think nonetheless, as I said, I believe in the innate good intentions of nearly everybody in who's working in health and social care, and in people at large. So I think if we can just allow them the room to do some good things, it's giving people that little bit of latitude, and trialing stuff and not being afraid to fail, because nothing's perfect, but we need to, the status quo can't be sustained.
Completely agree. And as someone who's been putting together voluntary sector alliances for a few years now, you do need a bit of movement. You can't endlessly meet in dusty village halls and talk about the perfect. You've got to have very slowly moving, but with the door open, and say, come on, jump aboard. Suad, I see you coming in. Over to you. Yes.
Oh, you me?
Yeah.
So yeah, no, I just wanted to say, like, mental health it doesn't happen in, I'm trying to think of the word and I'm not very good, but it doesn't happen, it's not just on its own. There's like housing crisis, or there's financial crisis, or it could be something like your child's being expelled from school. And we had the Be Kind movement, and to me that didn't sit well. To me, I think be gentle. So like if you work in housing and you get somebody coming and sitting down who's high rate, instead of already letting your auntie get up, think to yourself, what is really going on here? And just be gentle when we're working with other people. It's not always easy when you've got somebody irate in front of you and the demand in the voice is raised, but sometimes it's just about taking that breath. And I think that's the message we need to get out, because it's not just in medical where we need understanding of mental health and what's going on. It's across all services, whether you work in charities or whether you work in a shop. It's like when somebody comes in and they're not looking so good, or they're raising the voice, or they seem anxious, how do we work with that? And the easiest way is just, how are you? What can I do to help? It's just that, be gentle.
Completely.
And that's where we can start.
Absolutely. And it is worth just noting really briefly that alongside the much reported crisis in the NHS, there's an unreported crisis in the voluntary sector, where just at the time people might be seeking help from Citizens Advice or from a small charity that's around, they're closing their books or shutting up shop altogether. So I think that thing of getting everyone together around the whole person, absolutely crucial. Suad, we were going to turn to you, but I don't know if there's a technical problem. Can you come in now?
Yeah, I don't know if everyone. It's interesting. I was hearing. For me, I believe the good in the heart of the people. I think it's not lack of people or lack of the money. It's the lack of right people in right place. That's one thing. And it's the lack of understanding. And at the same time, I mean, what you were saying is right. We interview now our research project for 2 years, and I did like series of art work therapy and art therapy workshop for women who are homeless. Did you know in whole Birmingham is not actually any service for homeless for Somali community or women? If it's there, they're not able to access it because they don't know it's existing. At the same time, the whole service is not understand them. But sometimes when we say we're talking to that, I think I always call some organization is family fair. And I think the family fair is, we're not challenging. People not ready for challenge. It's not about data. We're focusing on data. We're losing the meaning. And the people are not given right places. People not going to right people. It breaking my heart. I work with children. I give it therapy. I needed, after 6-7 sessions, I needed them go. And they didn't get what the right need. And we know all this is going on. But imagine there's people who not knowing and dying and really desperate. But the problem, I think, it will be if we saying, we look deep and we criticize ourselves and we keep the accountability to people who are actually saying we're doing this with that. It's ticking box. My problem is ticking box. It's so much ticking box. It's too much. But that is the only thing I would say. And I think people's life is not ticking box.
Absolutely right. Absolutely right. Amanda, let's bring you in.
It's really echoing what's already been said, and also Jade Ward in the chat, you've really captured it there, that actually, yes, we do lack resources. Yes, we are struggling with, sort of, particularly, in mental health, of feeling that the demand is outstripping, but we are not effective enough yet at sort of coming together in terms of across our systems, so statutory, charity, voluntary, and using that, but also working with people enough in order to help them feel that they can take that sort of control to help make those connections between people. So we do sort of, I think, often feel that responsibility to fix or come up with a solution, when actually we need to sort of, as you say, take a step back, Suad, and actually help build those connections and help people to sort of work towards the goals that are important to them.
Thank you, Amanda. I'm going to bring in James very quickly now before we move on to our speaker.
All right, we'll be quick then. So I guess that point around agency is absolutely critical, isn't it? Because, you know, we've talked a bit around power, control, and fundamentally that's what we all want in our lives. So how do we create the right approach around supporting agency? And frankly, there's, you know, we're over medicalizing issues. We're pulling people into systems that should never get anywhere near the systems that are involved. And that means that as well, we're missing those people who really do need intensive support. So we've really got to turn our thinking around this on its head. And I keep going back, the only way to do that is to make the right connections, to make what we're doing much, much simpler. And certainly for organizations like mine, to reach right out and be based right out there within communities, and to be listening and to be part of a community group. So we know the connections that are there in the community. And when someone needs more intensive support, then we can pull the right people in at the right time. So if we get this right, and it's all built on agency, it's a pull system rather than a system where you pass from pillar to post, as we've heard today. That's I think the power of what we can create, and it won't be created magically overnight. It'll be created, as Alisdair said, by like a million different, steps. And I think that's what we need to create the environment, is a sense of direction where we're working together, and let's prove that we can do it by making step by step along the way.
Thank you all, and really great discussion. And just as a parting thought, I think that the scale of the problems we face is enormous, and it's only when you see the whole community as the system that can address it that you suddenly start to see where the assets and the workforce that might make the difference is. But we can't will that without willing the means, which is people to make those connections, is investment, is a reason for people to be involved. And with that in mind, I'm going to introduce Claire Murdoch, who's our keynote speaker. Claire, you will all know, but just to say that with the community mental health framework, now 4 years ago, I think we saw some of these ideas taken in a really daring and bold way right into the heart of the NHS. So if that feels like a good enough introduction to you, to Claire, take it away.
Thank you. Thank you. And thank you so much, everyone. I have really enjoyed, it's not the right word, listening to you. I've been really stimulated and reflecting that this year, actually, I'll have worked in mental health services for 40 years. And I can point to some things I think that have changed enormously since when I started training as a mental health nurse. That's how I came into the NHS. But I can think of others where we're frustratingly slow, and you've named many of them today. So I think this is a really important debate. I want to say a few things, if I might. I do just want to say thank you for plugging the Community Transformation Framework, because that absolutely, we had £900 million nationally, the biggest slug of the 2.3 billion that we've had for mental health in recent years, for the Community Transformation Framework. And we tried to make something together with people from across the country, different backgrounds, different perspectives, that could talk to both some material deliverables. Some of you have been talking about the tick boxes, in terms of numbers of people seen or range of services offered. So we did need to do some of that. But actually, and crucially, I think that that framework was very much about the culture of services, the creativity and the permissiveness to deliver those community services locally and in a local context and with communities. And that was fully the intention of the framework. We're in year 5 now, currently, of the 5-year plan. But of course, we had huge hiatus in the middle of it with COVID. And in fact, that 900 million was backloaded to years 3, 4 and 5. So I think investment is still very much flowing. I guess listening to people, I mean, let me just start with, this is a very, very human endeavour. And I love so many of the phrases and concepts that have been used, and they speak to me personally as well. So that hope and purpose and mastery and control, but so many other things that people have said. So obviously it's a very human endeavour. In my national role, I guess I have to constantly think about talking to the politicians, lobbying the politicians, lobbying within the NHS to try and get resource that can then flow out of my hands or our national hands to regions, and now more recently to ICSs, and through ICSs to place, integrated care systems to place. And in order to get the money, you have to make some promises. You can't just say, give us some money and we'll do some good things with them, or give us some money and we'll distribute it with no measurement, no feedback about what's been happening to that public money, you know, nothing measurable. So you do make promises in order to get some money. But my view has always been that my job is to get some ingredients for a cake, and to say what those ingredients are, I don't know. At the minute, we're busily implementing mental health support teams in schools as a model in this country that, well, hopefully by the end of next year, will cover half of schools and colleges. And I can say more about that if people are interested. But so we said to government, give us some money and we'll do this. We obviously were really worried about the plight of pregnant women, new mothers who perhaps had mental health problems or experienced them at birth. And we knew that the extent of coverage of services nationally at the beginning of the 5 years was 14% of services had specialist knowledge. And that's not good enough. Now 100% of the country does. So these are ingredients for a cake. But I've always been really clear that we don't bake the cake nationally. We get some tools and levers into your hands locally, and it's up to you to bake that cake. You know, we prescribe some things in return for the money, but not most things, and not how you work, and not which communities you work with, not how you fashion your services so that they will meet the needs of local people. That's your jobs, I would say to people across the country. And I guess as I'm thinking about what we've achieved over the last 5 years and where we go over the next, and I think it was Alisdair who said we're leaning into a really, really turbulent, I didn't quite use those words, but a really turbulent political time now. We don't know who to influence. We don't know who will be in power. We don't know where they'll position mental health. So sorry, my dogs have been quiet all afternoon and have decided to bark now. So it's really important that we influence everyone at the minute to make sure that mental health stays positioned in a place where we do get more funding. I think as well at a policy level, some things people said about social care and where does the NHS stand on that, because you're absolutely right, Alisdair, and I love that sum. I've used it myself, that even if somebody gets an hour a week or 2 hours a week from mental health services, hello, there's the rest of their life. Where are people living? What wider supports they have? What are the supports and funding? So many grants that used to go to local authority charities, especially smaller charities. And these grants have been so severely threatened or dried up. Housing is a massive problem. I'm really clear where I stand on social care, but there is a grey area. So I, together with, in fact, Rethink Mental Illness, with Mind, with Young Minds, with a whole range of charities. I was out last night at a meeting with the chief execs of sort of the major charities and think tanks, talking about how do we get that narrative across that actually says social care, housing, the wider determinants, for want of a better word, must be funded. And how do we as an NHS, when we do get money, not be so, what's the word, rigid in what it can be spent on, that, oh, somebody's saying, I'm sorry, who is the current speaker? Hello, I just saw that flash up. Sorry, I should have perhaps introduced myself. My name's Claire Murdoch. I'm the National Director for Mental Health in England, working for NHS England. So that's who I so that's who I am. Sorry, I should have introduced myself. So in terms of social care, we have to be advocating for more and talking about the important infrastructure that we have to support vibrant communities and help people have places to live and so on and so forth. And in health, yes, our main job is primarily assessment, diagnosis and treatment. That's sort of what the NHS does. But with the money we get, we absolutely, and I think the community transformation framework was a good example of this. I'm trying to make sure we really lean into being as permissive as possible, funding really different models of care, really hoping that the ICSs and others, local places, will spend the money really differently. I can think of 3 examples, actually, 2 more recently during COVID, but one before. I came to visit ReCoCo in Newcastle a few years ago now, before COVID, and I was really struck by some really practical things that have stayed with me since, and I've quoted often. I was struck by the fact that there was a sort of skills and services exchange going on in the place I visited. So if I was good at tap dancing or plumbing or whatever, people could give classes and exchange skills and empower and enable each other, or help each other with really practical things in life. I was also really struck that on the day I visited, quite a few people at this centre were getting on a bus to go and have training in DBT. And these were service users who were being trained in DBT and were going through that, i.e. empowering, if there are useful skills that are traditionally dubbed as clinical, hello, share them and enable others to help themselves and each other. So, you know, that things like that I saw that day had a massive impact on my thinking about communities and individuals and health creation, and how the NHS could support that. In more recent years, I suppose, perhaps one of the most powerful influences on me has been work in my own trust. I'm a chief executive of an NHS trust as well, with the Grenfell community or communities. And in fact, I met with them just last week, and they, 6 years in after that terrible fire, and the repercussions of that still so very live. And I was really struck about how they talked about the health and wellbeing offer that had been created, and by my trust, but very much by them and with people from Grenfell. And we were reflecting on how many times we got it wrong, how angry we often made an already really angry and distressed community, but actually how my colleagues who worked in that service have changed beyond measure, both their interpretation of the clinical evidence base, the way that it's offered, the place that that support is offered, and how now, together with the Grenfell community, that's under constant review all the time, whether that's for their children and adolescent populations, or whether it's for the adults from sort of diverse backgrounds. And I'm really thrilled to say that it's now something that's really valued in Grenfell, and hugely, I think that's because they feel mastery and agency and control. It's their service, it's not ours, but we are very privileged to be providing it. And another example from COVID that this all makes me very much think of is a community in Brent where many people are were from Somali backgrounds, where in one street, Church End, nearly 40 people died in a really short space of time at the beginning of COVID. It was horrific. It was the worst death rate ever. And people felt abandoned by the health service. And we had a real sense we had to do something. And although my trust provides mental health services in Brent, and this was obviously very much dying from COVID and therefore physical health, actually, I think the route to so many approaches to better health is this health creation, i.e. for and with local communities, local peoples. And a year on, after working in really very different ways, very much led by the local community, who didn't always know, who did then, both with Grenfell this was true, but also with COVID. Nobody knew all the answers, but that human to human dialogue, that thinking about how you use already existing assets, both in people and in communities, thinking about how then you pivot what you do as the NHS and spend your money very differently on the health offering. A year on, it was really wonderful there to see that community feeling that they had much more control, they were less fearful, they felt they were living healthier and better lives. So I think there are some things we can practically do, and lifting some of those lessons, and indeed the health creation sort of framework, taking the principles of that and being able to work very different much more quickly, I think is definitely something we need to be doing over the next few years. And I think our next mental health plan, when we create it, needs to say much more about all of this. I did just want to, I'm just looking at the notes I made listening to everybody. I think there is an issue about toxic, some of the more toxic elements of our society currently, whether that's social media or industry that pumps things at people that really prey on them. You know, doing a lot of work at the minute around the gambling industry. But for me, there is something about, we can tackle these unilaterally, some of these sort of wider impacts, obviously social media and so on and so forth. But actually, I think we do need communities to exercise more voice. I think we do need to influence policymakers and politicians to really look at some of the wider conditions that lead to a better and healthier society. And I do think as an NHS, one other thing that we can and should be doing that really resonated with me was this siloing of people and the conditions or illnesses that they have or are faced with. And mental health and addiction is a really obvious one that's really unforgivable. And I've undertaken to work with Carol Black, who's been leading a lot of work nationally for the government. I've undertaken to work with her, people with lived experience and others, to try and create a different model over the next 5 years there. But also physical and mental health. I met with Theresa May this week, and she'd just been doing a piece of work on type 1 diabetes. And guess what she found? Huge mental health and emotional impacts of having type 1 diabetes and how you manage it. You know, we know this, people are not just carved up into silos. This cut off at 18 and the way we organise services, and then you go again when you're 18 in a day, you know, you're a child until you're 18, and then you're 18 in a day and you're all an adult, and we change your services. There are some big silos that we're working on, but again, I recognise we need to go further, faster with. I think I've probably said enough for now, because people may want to ask questions or you will want to continue the debate. I just want to say, I think local systems who say they're tied by the national plan are being lazy. Eek. I've said it now. I think there is plenty of scope to ask forgiveness, not permission, around doing things differently. Yep, let's be pragmatic. There are some deliverables. I promised we would see 60,000 more women a year by the end of the 5-year period who had perinatal mental health problems because they weren't being seen. I promised that, or we promised that, to get some money to spread specialist perinatal services across the country. I'm not telling local systems how to do it. I'm not telling them to silo that from if there's an addiction problem or a housing problem I'm saying see 60,000 more women who need help and support at really vulnerable time of their life, work with them. So I just want to say, I think we all need to be really careful about accepting constraints that may not be there in quite the way we think. And if I might just end with a joke, and forgive me, but 2 Roman Catholic priests, and they're chatting, and they find as they chat that the Holy Father allows one of them to smoke and pray at the same time, and the other one isn't allowed to smoke and pray at the same time. And they get to talking because the Holy Father is a fair man, and this just didn't make sense. It was absolutely baffling. So they try and work it out, and in the end they say, well, what did you ask him? What did you ask him? And one of the Holy Father's priests said, well, I said, Holy Father, when I'm praying, is it all right if I smoke? And the Holy Father said, certainly not. Praying is a sacred activity. And when you're praying, please focus on that, my son. Well, what did you ask him? Oh, well, I said, Holy Father, when I'm smoking, is it all right if I pray? And the Holy Father said, my son, you can pray anytime. And I only leave that with you because it was a joke that an academic professor of psychiatry told me years ago. And he was basically saying, let's reset the questions that we ask, and let's think very carefully about the context we're in. I think the next 5 years, with so much to build on and so many great examples, yet so much to change, I think the next 5 years is time for health creation, for local communities, for people where the expertise sits, where people are living their lives. I think it's time to sort of storm some of what is available and fundamentally change it. And I would say, be really demanding of your new ICSs. They've been developed to think differently and plan differently around the needs of local populations and more holistically. Will they do that? I can guarantee they won't unless they're helped by local community groups, local charities, other local organisations, and look at health in its broadest possible context. So I am speaking with some humility because I know there's a limit to what I can do. On a good day, I feel I might get some more money and I might be able to get some more resource out the door, but I'm not baking any cakes, you all are.
Thank you very much, Claire. As ever, much to think about, and just pull out that call that at this time of political change, we all need to make the case about the challenges around mental health. What's the biggest driver of people out the workforce, but also the fact that we are quite good at baking cakes, and we'll do something useful with whatever resource we can get. And I'm now going to hand over to Neil and Merron to the breakout rooms. Thank you.
Thank you. Just 30 seconds just to say thank you, Claire, and thank you for being a keynote listener as well as a keynote speaker, which is so important, and it's, you know, we value that hugely. I'm mindful of what you were really saying is we can all be change agents, and that's one of the things that the Health Creation Alliance is working on, you know, to sort of connect and grow confident leaders for health creation. And you also mentioned the constraints getting the money out the door, and we've always thought and felt that because we created the framework from the perspective of communities and what they said made the biggest difference to their health, that this could be a framework around which measurement is is attached, and potentially that could persuade some of the powers that be that these areas, if we can get that measurement right, could be a valid place to invest, and we really would like that to happen. So I will probably be emailing you after this to say, can we talk again about how we might make that happen? But I'm not going to spend any longer on that, but thank you very much.
Thank you very much for that. So I will, if we just hand over to, if we kick off just very, very quickly, if Will could just summarize in a few sentences some of the key discussion points from your breakout group, followed by Hazel, and then we'll, followed by Lynn, but hi Hazel, followed by Lynn, and then we'll hand over to Merron, who will summarize her group, but also close the meeting for us. So over to you, Will.
Brilliant, Neil. Thank you. There's so much good stuff. It's hard to canter through. We're looking at some of the kind of pinch points really in the community where this kind of approach around health creation could really work. We talked about mental health and addiction. We talked about issues like hoarding and being able to work with people and housing associations in a much more human way, about carers and their needs, and young people facing into a summer without support from their schools. We talked about some of the amazing assets that are out there, and then really how they're never quite joined up. So it's hard to find them together, it's hard to navigate them, but a more kind of systemic approach could really make a difference.
Thank you very much, Will. And over to you, Lynn.
Thank you. So I hope this reflects what we discussed. The group were fantastic. So we started off with a discussion about the dominance of the traditional medical model, and that colleagues are seeking to change this, a culture change, but that doesn't happen overnight. We had a discussion about national policy and the need to include the policy decisions of other departments outside the NHS on mental health, because some of the positions they take undermine mental health. Further discussion about the national picture and that politicians will not have a magic answer, and more discussion about the culture change that was needed, that transformation, that many of us will hear that word, does not take place in darkened rooms, but with our communities and families, and it will take years. It won't happen overnight. We also had colleagues on the call who had experienced health creation in action and could affirm that the 3 Cs, adopting the 3 Cs and a new order emerges. There was a general agreement that people can get stuck on the conversation about money. And then finally, we'd only just gone on to question 2, Neil, I'm sorry, but just a reminder that at one point we had huge hope about addressing health inequalities, the Oneless report, and the role of everyone, businesses, teachers, the role of everyone in the contribution to addressing better mental health for our communities.
Thank you very much, Lynn. Thank you for that. And then I hand over to you, Merron.
Thank you, Neil. And in our group, we talked about the possibilities where people with lived experience of poverty, trauma and discrimination can work alongside students and professionals in a sort of mentoring or buddying relationship. And some people have found that very empowering, actually, compared with other types of engagement. So seen very much as equals and going on a journey of changing how new service providers work. Then also the idea that there is a much bigger need for more peer support and making it much easier for people to get access to low-level support, it was termed, but the things they need really from many different places and community settings, not necessarily needing a clinical specialist often for some of this stuff. And then an appeal was made by Suad on if you're not seen, what point is an intervention? If you're just not being seen for who you are, you're just being seen as one thing or as a label, and then what use is that? So we will be making the slides available, including Suad, so we can go back and reflect on that that slide you put up about solutions, and very helpfully how we might start to pick through some of that and unpick some of this unconscious bias that is, pervades everything. So thank you everyone for contributing today. The breakouts are only short, and we're aware of that, but we had rich content, and please share in the chat what issues you would like the Health Creation Alliance and Rethink Mental Illness to focus on going forward, what you think is most important that's come out of today. So you've got a few minutes left as I'm closing to do that, and we will be able to pick that up, and we will be thinking about that. So I just want to say thank you to all our speakers, to Lisa, to Suad, to Alisdair, James, Amanda, and to Claire. And it's been a very high intensity discussion, and I feel like I've learned a lot. So thank you all for that. Thank you to Rethink Mental Illness, William, and also Samantha Holmes, who couldn't be here today because she's on a flight, I think, right now to a holiday destination. But she's done a lot as well behind the scenes to make this happen. So we're really pleased and thankful to you for enabling us to make this happen. And thank you to everyone who's attended today to make it such an interesting and rich discussion. Just a few reminders: the video will be available from our website within a couple of weeks, on the coming of age page as well, along with all the other videos and presentations from the previous events that we held in October. If you haven't seen them, please have a look. And we will sign you up as a member for free, unless you've expressed otherwise within the chat. So please do be aware of that. You can always unsubscribe at a later date if you don't want to receive information from us. And also to make you aware, because we probably haven't made our members aware enough, that Health Creation Alliance offers a range of, if you like, services or learning to different parts of the system. We're cross-sector. We have lived experience leaders working with us on much of that. So we do workshops, action learning, communities of learning, wholesale transformation. We have started to do. So we reach the parts that others don't reach. I think we offer something that the big consultancies consistently overlook. And we work with many partners. So please think of the Health Creation Alliance if you're thinking of support that your system might need to transform. We can play all sorts of roles. If you think your system's ready for that, do get in touch with us for a conversation. We will be sending out a menu of options in a couple of weeks' time, just to start your thinking widely to all of our members to look at what that offer might be. So that's it from the Health Creation Alliance today, and thank you so much for making this possible, and for the inputs. I've both been challenged and I've enjoyed it because it has been such a rich conversation and so much to do in this area. But I wanted to say thank you all very much, and the meeting will close now.